Good afternoon, everyone. In this ADIPOSE arena hall, we are about to start the post-lunch sessions. So it will be integrated metabolic care, pearl of wisdom. For this, I would like to invite the chairpersons, Dr. Supriya Datta, Dr. Orkojit Ghosh, and Dr. Alisa Acharya to be on the stage and do the further proceedings, ma'am.
Hello. Good afternoon. People are in a mood to eat, so the hall will fill slowly. Let them fill their tummies. So we have a huge thing, integrated metabolic care and pearls of wisdom for this. This is an important session, but anyways, people will come. So without wasting time, I wish to introduce, the first topic and the first speaker. This is complications related to diabetes and impact of herpes zoster on patient with diabetes and its prevention. To talk about this, we have none other than Dr. Gaurav Bhaduri. He needs no introduction. He is a consultant endocrinologist and diabetologist attached to several hospitals and has several credentials to his name, and he is one of the executives and founder of this conference. So Gaurav, begin your session.
First of all, a very good afternoon to everyone, and thank you, ma'am, for the very kind introduction. So today I'm going to talk about impact of herpes zoster on patients with diabetes mellitus, and we will take you through the main part, that is how you can prevent it. So this is the disclaimer. I'm not a GSK employee, but I have been contracted by GSK employees, so this is a sponsored session, and the slides are made by GSK. So why is this not moving? Which one? Yeah, yeah, yeah. Okay. So it's not moving over here. Okay, okay. But we are different over here. We are not in this slide, right? Just point it to the slide. No, this is not the first slide. So this is up here. So fine, I will continue. So yeah. Okay. So this is where I were. So I'm not a GSK employee, but I'm going to talk about this is a sponsored session, and I'm contracted by GSK for this talk. So you look at the diabetes and where we stand today. So about 101 million, diabetic patients we have, and this is a data of 2023. So by now we are having even more than that, and a pre-diabetes of around 136 million from the ICMR 2023 data. So India itself has got a huge burden of type 2 diabetes, right? And then you look at the herpes zoster in your type 2 diabetic patients. So this is the data. You look at the incidence of herpes zoster in diabetes population, and it ranges from 7 to 15 per every 1,000 person years. So that's a huge number. And if you look at the risk ratio for our patients, what we find is that the risk ratio in almost all the studies which has done it is actually exceeding the number 1. So it means that there is a much higher risk. And if we segregate the patients from around 50 to 60 years, and then 60 to 70, and 71 to 85 plus, what we see in every situation is that your healthy patients versus your diabetes patients, so your diabetes patient has a much higher risk of getting herpes zoster at every different spectrum of the age band. Now, this is another data showing you that this is not a unidirectional problem. Herpes can also influence your blood glucose control. And this data over here shows you that 24% of very well-controlled patients of diabetes having a HbA1c of less than equal to 6.5 were having increased HbA1c after the patient got affected with herpes. And if you look at the length of stay and the medication used like insulin, they were also increased, but albeit statistically they were not significant, but there was a numerical increase over there. This, again, slide tells you that it's not only about diabetes. These are all the comorbidities that we have listed over here, shows an increased risk of herpes zoster. If you get affected with this conditions, you will have a much higher incidence of herpes zoster. Now, this study shows you that if you have one disease, your risk goes up, that I've showed in the previous slide. Here we are showing that if there is two diseases together, suppose diabetes mellitus with cardiovascular disease, diabetes mellitus with heart failure, or even a COPD with a heart failure, so your risk is even higher. Now, this right-hand panel shows you two age bands, right? So one is this 50 to 64, and another is more than equal to 65. So if you have two conditions like diabetes and cardiac disease versus three conditions, that diabetes, heart disease, and COPD, so having three conditions increases your risk independent of your age. So more the number of comorbidities you have, the higher is the risk. Now, when we talk about herpes, it's also important to understand from the patient's perspective, because the patient quality of life is compromised when they are getting an infection such as herpes. And what is most affected is the sleep. So that's the, this is a survey-based result showing the sleep is the one component which is most affected, followed by enjoyment of life and general activity. So patients feel that there is a limitation to this activity. And again, over here, you see whether it's the impact of herpes zoster or the impact of, post-herpetic neuralgia. The pain, anxiety, discomfort, and usual activities are the most reported issues in our patients. Now, how good is the efficacy of this, right? So before we go into the efficacy data, we need to understand what we are doing in the vaccine to mount the immune response. So we have the antigen glycoprotein E, and it elicits a specific immune response against the varicella zoster virus, and is expressed on the surface of the VZV infected cells, and this is a key to replication. So we isolate the, the glycoprotein E, what we call as GE, and we, design the vaccine around this. But we need also a very important component is the adjuvant that goes into the vaccine. Because until and unless you have the adjuvant, you won't be able to mount a very strong response, and that to sustain the response for a longer duration of time. So the adjuvant is ASO1B. This is comprised of two components. One is the MPL and one is the QS21. And what they do is they are able to mount a cellular immune response. So the previous generation, the aluminum-based or the alum-based adjuvants, were able to mount a good humoral response, but not an adequate cellular response. And we know in our viral infections, a cellular response is almost a necessity to mount a good efficacy of any vaccine, as well as to maintain and sustain that efficacy for a very long duration of time. So exactly this is what you see. So with the adjuvant, you see a very sharp rise of the immunogenic response, and then that sharp rise, albeit it falls a little bit, but it is maintained for a very long duration of time. Now, if you look at these two were the most pivotal study, the ZOA50 and the ZOA70 for the herpes zoster trials, and they also did combined this two data, and this was pre-specified, and the primary objective in the pool analysis was a post-herpeutic neuralgia efficacy and the herpes zoster prevention efficacy, both in 70 years of age. And let's look at the results. So in the ZOA50, what we see is that irrespective of the age band, you have more than 96% efficacy when you're using this vaccine. And in the ZOA50 to 70, if you pool and see it more than 70, 70 to 79, and more than 80, what we find is at least more than 91% efficacy being maintained. So that's very, very robust. So irrespective of what it's preventing, either it's preventing against PHN or maybe against other herpes zoster related complications, most of the time the numbers are more than 88 or 90%. Now, this is the data of the long-term follow-up trial of the ZOE, showing that even 11 years down the line, the drugs are able to maintain a more than 80% efficacy once you have given the shot. So as the data stands now, as of now, we have 11 years data showing that once you give it, till 11 years, it's maintaining it. And this study will continue as we move ahead in the future, and we will see how long it is able to keep the good efficacy for a much longer duration of time. So that we still don't know, but till 11 years we have clear, robust data. So most common adverse events are pain, redness, and swelling. Sometimes fatigue, headache, myalgia may be reported, but we know this is true for every vaccine that we might give. But more important is the serious adverse events, or maybe the fatal adverse events, or whether you want to know that whether it leads to any immune-mediated disease. And there you see the Shingrix versus the placebo, everywhere is exactly similar. So Shingrix was comparable with placebo in overall incidence of either a serious adverse events or a fatal adverse events or immune-mediated disease occurrence risk. So very safe. So how to use it is given in 2 doses, one followed by next dose after 2 months, and then you can extend it up to 6 months, but within that period you need to give once you have given the first dose. And it's supplied in 2 vials of reconstitution, and once you have reconstituted it, it's better you use it immediately. But if you store it in a 2 to 8 degrees centigrade, then you can keep it for a maximum of 6 hours, but do not freeze it. And it's only for intramuscular injection. Now, if you look at the different guidelines, everywhere they say that more than equal to 50 years of age, you should be, giving your patients this particular Shingrix vaccine or the herpes zoster vaccine. And even in India, if you look at the guidelines, the API, the Research Society for the Study of Diabetes in India, again, very similar guidelines coming from there. And it can be co-administered along with the more common vaccines that we give in our patients, like an immunococcal vaccine, pneumococcal vaccine, or an influenza vaccine. You can be using it in your patients, co-administer them as well. But most of the time, we don't co-administer. We usually space it out by a couple of days. But if you want, you can co-administer. Data is very robust over there. Now, you see, once you have given a dose, suppose 2nd of January, you can repeat it after 2 months from March 2 to up to July 2. So from the start date up to 6 months. So within that frame, you need to give it. It's a 2-dose regime. Now, this is a very important question that if you have a patient who has got it, a herpes active infection, then when do you plan to vaccinate that patient, or whether that patient needs vaccination at all? So there are 2 groups of thoughts over there. So one is the USA CDC group, which says that vaccination should be delayed until the acute phase of the infection is over. Usually in the consensus, it's about 2 months' time. Another is the Canadian authorities. They say that up to 1 year of infection, it mounts a very reasonable, antibody response. So till 1 year of infection, you need not vaccinate. After 1 year, you can vaccinate these patients. So it's open to debate. It's a gray zone area. You can follow either schools of thought. Now, when you're using this, you have to remember that it can be used with most of the immunosuppressants. But so I started a little late, so I will take 2-3 minutes more. So rituximab, you see, you can use this with most of the immunosuppressants except the rituximab and the corticosteroids, where you need a little bit more nuanced approach. So for rituximab, it has to be deferred to more than equal to 5 months at least after the last dose of rituximab. And if you're using a corticosteroids, which is more than equal to 20 milligram of prednisolone equivalent, then you cannot use this vaccine until the dose has been tapered to less than equal to 20 milligram of prednisolone or equivalent. So these are the 2 take-home messages as far as this is concerned. Now, it's now approved in 51 countries with 26 national recommendations. Because of this very robust data, most of the countries across the world have accepted it and has also formulated national recommendations based on it. So, as a summary, what we understand. So, this Shingrix vaccine has gotten more than 90% efficacy across groups above 50. In certain studies, it's more than 95, 96%. 11 years long-term protection data is available with us. So with 2 shots, you can protect up to 11 years. And the study is ongoing. We don't know it's going to be 11 or maybe even 15 years. So as of now, we know that the efficacy can continue up to 11 years. Maybe in the future, we would know that it might continue even longer. Who knows? Recombinant adjuvant vaccine, and it's a non-live, and because of the adjuvant, it's able to mount such a robust efficacy, and it is also able to continue that efficacy for a very long duration of time. It's approved for use in adults aged more than equal to 50 years, in diabetic patients, because I treat that disease very specifically, so we always ask our patients, but even if your patient is not a diabetic, if he has touched the age of 50 or crossed it, the guidelines tell you to use it. Even the approval that they have received is also for the same. So adults aged more than equal to 50% is the indication, and it's very well tolerated. The serious side effects, the fatal side effects, and the immune-related disease are exactly as same as the placebo. So I thank you very much for your patient listening. I'm here if you have any questions for me. Handing the session back to Chairperson.
Thank you very much, sir, for the wonderful talk. So, any questions from the audience?
Good afternoon, sir. I just wanted to ask you 2 questions. One is like nowadays, children are getting a chickenpox vaccination, right? In their normal vaccination trials. So when they will be in the like post 50 years, if they are not having chickenpox in their younger age, will they be suffering from sniffles?
Yes, they still can, because sometimes it's not an expressed infection, it's a dormant infection.
Yeah.
So then those patients will also be at risk when there is a natural immunosenescence that happens at 50. So that is why the age of 50 was selected, because that's where the curves of risk of infection starts going up. So even if they have received it and they haven't gotten chickenpox in their earlier days, so when they cross 50 or they're aged more, they should be receiving the vaccine.
And the second question is, as you said, it is providing the total tenure is around 11 years of protection. So is any booster dose advised after that?
No, see, that is a very good question. I would really thank you for asking this. So sometimes when we talk in a very short, 15 minutes talk, this gets confused. So the study was started in 2014. Okay, and this data is of 2025. So 2026 data is yet to come. So from 2014, those patients who were given the first batch of users, those patients on 2025 maintained a good efficacy till 11 years. So as we move into 2030, we might see that it's working even the next 5 years as well. So until that data comes up, we know as of now that it's 11 years, it maintains the efficacy. Whether it would maintain the same efficacy at 15, 20, 25, only future will tell. So we don't, it doesn't mean that it's only up to 11 and then we need to give a booster. When to give a booster, we don't know. Whether to give a booster at all, we don't know.
Thank you, sir.
Thanks, Dr. Bhadudi, for giving an excellent deliberation and informative too. Now, we were taught and we used to teach also that chickenpox, also having varicella zoster virus varicella virus, gives almost a lifelong immunity once you get infection. First of all, that varicella-induced chickenpox, they generally do not give any protection against herpes zoster. And so you have to give vaccine if the patient's age crosses 50 years, preferably if he is diabetic or having so many comorbidities. Now, so chickenpox gives immunity, but herpes zoster, does it give any immunity? Once a patient develops, suppose in the early age, gets chickenpox, and again he gets herpes zoster, these two infections, does it confer any immunity on the host?
Yeah. So, sir, what happens is, first of all, Professor Jana is my teacher, so thank you, sir, for my asking this question. So, what happens is, chickenpox, getting a chickenpox doesn't give you protection against the herpes zoster. But getting a herpes zoster provides some degree of protection to future herpes zoster. Now, there is a debate that once the infection is there, how long would that give the patient protection against another episode of herpes zoster? So, the US lobby says that after 2 months of active infection, it's fair to vaccinate the patient for future risk of infection. The Canadian group says that it's better to wait at least for a year, because after 1 year, the titer starts falling of the previous infection. The protection lasts for about a year. So after 1 year, you vaccinate the patient so that the patient maintains a good, robust antibody response for at least 11 years that we have data as of now. Thank you.
Thank you so much.
I've got a question.
Sorry, there are so many topics here.
Just one point. Supriya, please. The question is, 50 years cut-off mark is there for starting this medicine. But will you advocate this medicine or the vaccination for diabetics? What duration is important, but I am getting patient who are than 20 years diabetic at the age of 50. So will you lower that cut-off mark in that patients?
Yeah. So you are asking that the patient has got a 20 years of diabetic history and the age is less than 50, right? Yeah. Then what to do? So we don't have approval for it. Less than 50, we don't have approval only because of diabetes. Okay. So in those situations, it's better to let the patient cross the age of 50 before you vaccinate. So that's because that's what the approval is. But for very high risk patients, individually you might think a little bit different, even for patients who are less than 50 years of age. Because the data shows that after 50 years, the risk goes very sharply up.
Particularly, forget about type 1, but the other types of the immunological diabetes.
Yes. Thank you.
Thank you, sir. So moving on to the next topic, we have advancing T2DM management. And the speaker for this session is Dr. Supratik Bhattacharya. Okay. So moving on to the next session, which is interpretation of AGP report. This will be taken by Dr. Rakesh Parikh. Sir, kindly. Okay. Sir is the Secretary General of RSSDI and founder of Metabolic Society Jaipur and co-founder of DTEC. Over to you, sir.
Thank you, Supratik, and the organizers for inviting me to speak on the topic, which is AGP interpretation. So I'm sure most of you would be aware of CGM, which is continuous glucose monitoring, and you must have seen the device used for continuous glucose monitoring. AGP is basically a software which analyzes the data collected by the CGM and creates a report that can visualize and give you the information about the patient's glycemic profile. If you want to learn more about CGM and AGP, then it's the conference that I would recommend to you, DTEC, which is happening in Mumbai this year in the month of May, and Dr. Purvi Chawla is the organizing secretary. He just joined us here. Now, CGM and AGP interpretation is a very interesting topic. I learned a lot of these things from Dr. Manoj Chawla, and some of the slides that I'm using, those are also borrowed from Dr. Manoj Chawla. So, as we know in the CGM will capture the glucose levels of patients at an interval, which is 15 minutes in the earlier versions, and now every minute it captures the blood sugar levels. So if you see the upper part of the graph, these are the line charts showing the glucose profile for different days. And AGP basically converts that data into a modal plot like this, where you can visualize the overall variations in the patient's blood sugar levels. How does that happen? To give an illustration, I made this slide using a AI tool. So imagine that these are the different values for different days of blood glucose level of a patient. And if you look at the numbers, it will be like this in the tabular format. So these are the values of glucose at a particular time point on different days. Based on these numbers, the software will calculate the median of these values, also the 25th centile and 75th centile and 5th and 95th centile. And these are the 5 values that will be obtained for each time point of a day. And based on these numbers, then the AGP plot is plotted. So here you have 5 lines. The central line is the median value. Then the other 2 lines are for 25th centile and 75th centile, and the last 2 are for 95th and 5th centile. So basically AGP just merges all this data for all the 14 days into a model plot so that you can get a visual impression of the glycemic variation of the patient. And it helps us in picking up the hyperglycemias, the hypoglycemias, and also tells about the glycemic variability and stability of the patient's glycemic profile. So now coming back to the same AGP graph again, I'm just re-emphasizing so that the concepts are clear here. We have 5 lines here. The central line is basically showing us the median value of glucose for that particular time point throughout the 14 days, if it's a 14 days AGP. The second is a band which is having 25th centile and 75th centile. So most of the values fall in this particular band, and that is called as interquartile range. And the last band or the outer band is called as interdocile range, and it captures the values between 5th centile and 95th centile. So the lighter band actually has the values which are not very common. The most common values are in the darker band. Still in the AGP graph, 5% of the data above and 95% below the 95th centile will be lost because that is not captured in the AGP graph. Now once you understand the AGP graph, then these are the 3 basic metrics that we all must be aware of, that for AGP, normally the target range is kept between 70 to 180, although it is adjustable and you can modify that when you analyze the report. So if you keep the target for this patient as 70 to 180, the time that the patient spends in this range is called as time in range or TIR. The time that the patient spends above this range is called as TAR or time above range, and the time below this range is called as time below range or time below range. Now how do you get this AGP graph for your patients? So if your patients are on CGM, they just need to connect with you using the mobile app, and then at your end you have a dashboard which is Libre View. For this Libre sensor, if you are using some other sensor, they will be having the different dashboard also. So when I go to my dashboard, I see the patients of mine like this, and then for any patient, you click on the patient and you can see the AGP graph of that patient. In addition, you have an option to make the settings about how you want to see the reports. So if you click on that right top corner, then you get the options for your report where you have the preferences that you can set, and these are the preferences that you can set whatever reports you want to look at. Now we'll go through all these options which are available for a AGP report of a patient. So this is one patient of mine, although it's a little older patient, the slides are older. So when you click on the patient, then you will see all the previous AGPs of the patient. It will show you 2 weeks duration. So the first one is the latest one, and then earlier one, and then earlier one. And along with that, you will be shown the AGP graph just to summarize it. And then on the right side, you have the option to scroll through the different months. You can click on any month and choose the month that you want to analyze. Then if you click on glucose report, then it will show you the latest one, the complete report of the AGP graph, and all the parameters that you selected in the preferences will be shown here. So these are all the options which you have selected already. When you click on the first one, you get the basic summary of the AGP report. Now in this basic summary itself, there is a lot of information which is useful. So here you see the number of days data is shown here. It is 14 days, and then time sensor active, which is 84%. So the data which is captured here is around 84%. 16% data is lost for some or the other reason. Then in the bottom, it shows you the average glucose values for the 14 days, which is 124. The next indicator is GMI, which is glucose management indicator, which was earlier known as eHbA1c. So it correlates well with HbA1c. The value is just because we are used to HbA1c. So if you take the HbA1c of this patient for only 14 days period, it will be 6.3. And then the last part is glucose variability, which is 23.5 for this patient, which is pretty good. Should be around 35% or less than that. On the right side, it shows you all these parameters which are important, which are the time in range, time above range, time below range. And in time above range, it also shows you the time which is spent in very high values. And time below range, it also shows you the values which are spent in time which is below the 54 milligram per deciliter levels. Then you click on the next page in the same AGP report, then you will see the snapshot of AGP graph again, and then it also shows you the daily glucose profiles of the patient just in one summary for the whole 2 weeks period. Then the next part is again glucose pattern insight. So the first one gives you the summary in total, and then you get the details in the next slide. So the second one gives you glucose pattern insight. Again, the same things are repeated here. It shows you time in range, time above range, time below range, average glucose, GMR, and then it also gives you some considerations for clinicians. So some information that it can get from the AGP, it will give the information to you. And then comes the glucose patterns, where it shows you all the time points. So these dots here are actually individual values. So all the values which are captured by the AGP are shown here, and the AGP graph which is prepared by these values is shown there. So as you can see, the outstanders or the outliners are not included in the AGP graph because these are either below 5% or above 95% of the value. Then the next section is monthly summary. Here you can see the whole month's calendar. If the patient is regularly using CGM, then it will show you the monthly calendar, where in every day, the date is mentioned there. You get these 3 values. The one is the average glucose value, which is in the blue. Then the sensor views, how many times the patient has scanned the sensor. And if there are any low glucose values below the range, then that will be flagged as red. So you can see at some points there is a red mark, which shows the value is going down. Then the next is daily log. So here in every row you see a full day's profile for 24 hours. Now you can notice that on the first day the patient started using the CGM at around 8 p.m. The values started being captured, and on that day you can see there are 3 low values. So the values are also mentioned there, but the CGM values for the first 24 hours are not very reliable, so we should ignore these values unless they are confirmed by the SMBG and if the patient is having symptoms. Otherwise we can ignore these values. For the next days you can see the overall graph of the patient for the 24 hours. You can see visually which are the peaks that are there. So in the second day you can see there is a peak at around 8-9 p.m. On the next day it is flat curve. The next one is snapshot. Here again you see the AGP graph on the top. Then the second one shows you the low glucose events. So if there are any hypoglycemias, those will be picked up there, and it will show you the time point when the patient is going into hypoglycemias. And the next one is the sensor active time. So it shows you the overall active time of the sensor. The active time means the time when the data is captured. In addition, on the right side, if you can notice, then there is an option where it will show you the daily carbs. So this has to be entered by the patient. So if the patient is entering the daily carb intake and the doses of insulin that he has taken for both bolus and basal doses, then those will be captured on the right side and those will be shown here. Based on these, it also makes you comments. So the comments are there, which are generated by the AGP software itself. It will tell you when, if the patient is going into hypos, if there are fluctuations, if the variability is high, those things will be told to you by the AGP graph. Then the next is about mealtime patterns. So here it will show you the SMBG values, if the patient is also recording SMBG values, insulin doses, if the patient is capturing those, and the meal timings. So if the patient is telling you that he has taken meal and if the patient has entered the carb content of that meal, then those things will be captured. So my patient did not do that. If the patients take that many efforts, then those values will be also shown in the next slide. Then it's a weekly summary where for each day you have the graph and then also the mean average value of that particular day, and also if there are any hypo events. And again, this shows you in the yellow area which is going above range, so you can pick up the timings when the patient has got above range, and you can ask the patient if on that particular day the patient had some different meal, or if the patient made any changes in the medication, and so on. And the last one tells you details about the device that the patient is using. And then at the end, it also gives you the overall summary, the AGP graph at the top, the carb intake, and then also the insulin doses if the patient has entered those things. Dr. Manoj has come. Manoj, I have already acknowledged that the slides are yours and I learned AGP from you. So the next part, these are the 3 important things that we must look at when we are interpreting the AGP graph: variability, stability, and exposure. So I'll tell you the meanings of all of these. Exposure means the overall glycemic exposure of the patient. So we'll take median value for that. So this is the time, or this is the exposure that the patient had to glucose values. This is called as exposure. If the exposure is high, the TAR will be high, the sugars will be above range. The second part is variability, which is basically the inter-day variability on a particular time point. So in this particular case, if you can see between 8 to 10 a.m., you see that the variability is very high because the sugar levels are fluctuating between 300 and 50. The patient might go on hypo on a day, and there might be a peak on particular day. So the variability, which means the difference or the variation in the blood sugar levels on inter-day basis, on day-to-day basis. The third thing is stability, which means intra-day variability. So in the same day, if the glucose levels are fluctuating, that means that stability is low. So ideally we want the variability should be low, which means that the graph should be flat, and stability should be also low, which means that the graph should be stable. In the day also there should not be any peaks and troughs. So now for this particular, just 1 minute more. So for this particular patient, this is the AGP graph. We can see that this is the TIR, which is shown in the dotted lines, red lines, and then we have TAR by the time above range, and TBR also. We need to minimize that. So I'll just run fast now. What we can pick up from this particular patient, the median values are going high in around 10 a.m., which is the post breakfast period, and then it is moving very fast. And then there is hypoglycemias also, which are happening midnight between 4 to 8 a.m., early morning actually. So how do you intervene for these patients? First, look at the variability. If the variability, which means day-to-day variability, is very high, we need to advise the patient to address the lifestyle, do not have much of variation in the meals that the patient is taking. The medicine should be taken properly. If the patient is on insulin, might be there is a lipohypertrophy because of which the glucose levels are varying. So those things should be addressed first and minimize the variability. Once the variability is minimized, then you look at the stability. There should not be any peaks and troughs, and that can be done by adjusting the doses of the medicines or the carb content of the diet of the patient. And then you look at the exposure. So once you make the graph flat and narrow, after that, if the levels are still above range, then you bring it down. And for that, if the patient is on insulin, you can increase the dose of basal insulin or change the medicines for the patient. So at the end, I'm showing you again another slide, a similar AGP. The first one was very good. This is not very good. Here you can see that the values are very bad. The time in range is only 26%, 38% is high, and 36% is very high. This is the breakup of the, on different days you can see that the peaks are there on
Dr.
all the
Parikh,
days. Yeah.
Kindly summarize.
Yeah, it's last slide. Okay. Okay. Thank you very much.
All right. Thanks a lot, Dr. Parikh. I think Dr. Parikh is known to one and all in Kolkata. So, any question on CGM from the audience? All right. Supriya ji has worked extensively with CGM in Kolkata. So, we have a question from...
It's not a question, sir. It's a very simplified and very beautiful presentation for beginners at least, because it's very difficult to interpret anything. Just one thing we have to mention, because patients are always apprehensive when they see the red ones below 70. So we have to explain to them about the time lag and rapid fluctuations. It may be lagging behind because even with the capillary blood glucose also, they feel that it's a rubbish, they don't want to do. So those interpretations to our patients, we have to explain.
So time lag is expected with the CGMs, and there is a lag of around 15-20 minutes, which is expected. That's because of the technical problems, and secondly, there is a difference between the capillary glucose and the interstitial fluid glucose.
Yeah, because this is something practical we see in our patients, and also when there is rapid fluctuation or after exercise, so they may vary. That's all. Thank you, sir.
Thank you, thank you.
I think Supratik is not here, so please may call Dr. Purvi Chawla from Mumbai and kindly take us through about what's new in the 2026 update of AAC consensus regarding adults type 2 diabetes. Dr. Purvi Chawla is also known to all of us who are in diabetology or endocrine, so I'll not introduce her in that way. Okay. So, Dr. Purvi, you can proceed with your slides.
Thank you so much, and good afternoon, everyone in Kolkata. From City of Dreams to City of Joy, this was the announcement made by the pilot, and I loved it. So anyway, 2026 the ACE algorithm update is fresh off the oven. And it predominantly, because I don't know how much I'll be able to cover in like literally 11 minutes, but predominantly it's a change in philosophy. It's a change in philosophy and our thinking, because it's all now they are recommending us to follow a complications-based or complication-centric approach rather than, glucose-centric or weight management. It's all to do with using the right class of drugs right in the beginning rather than, first step and second step. Just look at the patient, profile that patient in front of you, and then use what you have in your armamentarium. Another very good aspect that has come up is actually that the type 2 diabetes, because we don't miss the other types of diabetes, there's a lot of thought process in how to confirm even type 2 diabetes. So that's another algorithm which is very interesting. I would urge all of you to read. It's a 32-page document, but beautifully given. Let me just go through the core principles here. And the foundation is basically lifestyle modifications, and they've really enlisted even sleep hygiene and everything else around it, even mood disorders in this. And of course, ABCD, which is adiposity-based chronic disease treatment, which is the absolute base of all therapy. So, there's a shift here. It's a paradigm shift as per their own philosophy, that it's not looking at glucose or weight or comorbidities. It's now looking at the complications straight on. So therapy selection is dictated by the presence of comorbidities, namely ASCVD, HF, CKD, MASLD, and also obstructive sleep apnea. And then precision tactics, which is targets and tech. So they do want to integrate CGM as well, which is a great and welcome move. And individualization of target with a strong recommendation for 6.5 and below of HbA1c. So this is like a holistic cardiometabolic risk profile, the Caramello syndrome, or the approach is coming back on in a big way. These are the core principles of algorithm 1, and I'm just going to read them out so it kind of stays with you. Lifestyle modification is the foundation of therapy. Using a comprehensive approach for weight loss to achieve clinical goals. Choice of pharmacologic therapy guided by glycemic targets as well as comorbidities, and they are named here. Choice of therapy also considers the ease of use and access, individualization of glycemic targets, and CGM metrics are put right in there. And optimal A1C is 6.5 and below, or as close to normal as it is safe and achievable. And avoiding therapeutic inertia. I think there's a very strong message there. Avoid the therapeutic inertia, and they've repeated this throughout the document. Avoid hypoglycemia as well. CGM is highly recommended, and comorbidities and complications must be managed for comprehensive care. Now the diagnostic triage checkpoint, and very clearly they are telling us do not assume it's type 2 diabetes, because you're just used to seeing that and starting off with what you would for type 2 diabetes. Definitely don't do that. Consider each patient very specifically with respect to the profile. Overweight and obesity can mask alternative etiologies, so confirm the diagnostic criteria first of all, and then if it's confirmed, then look at the phenotype of type 2, look at all the signs of insulin resistance, overweight, obesity, family history, etc. And then suspect other etiologies as well, like in a lean person, or history of DKA, absence of insulin resistance signs and insulin dependence, and then do the entire workup for type 1 diabetes as well. Look at other endocrine reasons for high sugars. Also, the pancreatic and monogenic types of diabetes should not be so this is very well integrated. Now these are not going to be just rare cases out of the textbook. It's going to be, because these are common these days, and it's occurring more commonly than it used to. So they're asking us to look at it more closely. The pre-diabetes intercept, yes, definitely prioritize ABCD or adiposity-based chronic disorder. And here weight loss is the primary lever to halt progression to overt diabetes, undoubtedly. And whether it's insulin resistance, signs of that, or early pre-diabetes or subcategories of it in terms of intermediate fasting hyperglycemia or IGT, whatever, you look at the patient and then look at how you can support the patient for weight loss, because we know that 7 to 10% weight loss halts the progression, and anything beyond 15% of baseline body weight loss will come with profound multi-system remodeling. And they have also given us specific drugs in case these are accompanied with ASCVD or OSA or dysglycemia persists over time despite weight loss or despite focusing on the weight tackling. Now coming to comorbidities, ASCVD risk reduction, and this is the 2026 lipid matrix. They're looking at the LDL-C pathway and asking us to initiate high-intensity statin, and if you've not met the goal, or there's not even 50% reduction, then add the ezetimibe. Not at goal, then further intensify with bempedoic acid, inclisiran, or even the PCSK9 monoclonal antibodies. And then for hypertriglyceridemia, there's an entire algorithm there as well, that if it's higher than normal, they've been very precise as to how we go about treating. I think this is not completely adaptable to the Indian scenario, because we also have drugs like saroglitazar, which are clearly not mentioned in this algorithm. But I think we have to individualize, but this is a new aspect here. Next, looking at, yes. So now for the blood pressure optimization in reducing the ASCVD risk, yes, this is how actually the ACE algorithm had always started, looking at first it was a simple glucocentric algorithm, and then 2013 onwards it was looking at comorbidities in terms of hypertension, dyslipidemia, and also weight. And then they looked at, a few years down the line, they said no, complications. But now it's clear ASCVD risk reduction includes hypertension, blood pressure optimization. The targets are well specified, step 3, step 2, step 1, very, very clearly defined here. And the cardiorenal synergy, they specify the SGLT2 inhibitors and MRAs like Findrenone provide distinct compounding benefits for patients with concurrent CKD and albuminuria. So there's again urging you to use these drugs earlier on than wait for later. Now the glycemic control bifurcation is also important, and the algorithm mandates a critical clinical triage before step therapy, definitely assess for comorbidities and complications. And yes, if you have the comorbidity-centric algorithm, then you decide on based on which comorbidity is prominent or exists, you can decide what is important and go that way. And know if there are no complications or comorbidities, then therapy is dictated by secondary factors like obesity, risk of hypoglycemia, severe baseline hyperglycemia, and definitely social factors like access and cost constraints are also very well highlighted here. But they are talking about definitely moving away from the step therapy that we used to, and ADA also does not recommend that. Comorbidities-centric pathway, which focuses on organ protection, and here there is selecting therapy, there is guidance on selecting therapy based on heart failure and CKD regardless of A1C. So that is one new change also, that tier 1 SGLT2 inhibitors for heart failure with reduced or with preserved ejection fraction, and then tier 2 would include GLP-1 or the GIP-GLP receptor agonists as well. And then they have come up with the warning, which also was included earlier, that TZDs are an absolute contraindication in NYHA class 3 and 4 heart failure. With respect to chronic kidney disease, tier 1 obviously includes SGLT2 inhibitors and then followed by GLP-1 receptor agonists. Rule of thumb here, avoid therapeutic inertia. And if A1C is more than 9% or above 1.5% above the goal at diagnosis, start with at least 2 complementary agents immediately. Again, with respect to vascular and hepatic comorbidities, they have very well listed out the drugs. I'm just looking at the ones which I haven't spoken about. For example, stroke and TIA history, first use the GLP-1 receptor agonist or even pioglitazone. And MASID, again, first line would be GLP-1 receptor agonist, then the GIP/GLP or pioglitazone. And they've described how we've changed the nomenclature to include MASID. They've also focused on the glucocentric pathway in case there are no established comorbidities or complications. And here, again, looking at overweight, obesity, priority, or hypoglycemia risk, or preventing that, or severe hyperglycemia, or again, access, cost constraints, very much there in the decision-making tree. And this has been, the algorithm has been generated by looking at all these priorities. Profiles of pharmacotherapy, I think this can be a great table even for physicians at the primary care level, right? Because with so many new classes, there is a lot of confusion sometimes in our minds, and this kind of a ready reckoner really helps to delineate what would be the choice for that particular patient. Insulin initiation and integration of CGM, this is also a very, just give me a minute more. This is a very interesting aspect where they have described how insulinization should be started with basal, and then the doses are based on the HbA1c cutoffs. Also the CGM targets are defined, and then the mandatory adjuvants always recommend a GIP GIP/GIP or a GLP-1 receptor agonist concurrently to mitigate insulin-induced weight gain or reduce total insulin requirements. So this is also very clearly given. And then over-basalization, it's just 2 slides more, I'll finish quickly. Over-basalization trap and the BAM score, which is nothing but bedtime glucose level minus the morning glucose, and then based on that, how you can initiate the prandial insulin. So this is also quite easy, but they have mentioned that don't over-basalize the patient, but you must know when to intervene with a prandial insulin as well. The obesity armamentarium is very specific as well, and the percentage weight loss with the different molecules that we have right now are also given, and the levels of weight loss providing the concurrent benefit has also been very well described here. So all in all, the 2026 synthesis is achieving the legacy effect. Remember, the keywords were avoid therapeutic inertia, glycemic optimization, organ protection with the correct use of the classes of drugs, and then risk factor normalization, which is addressing the aggressive BP, lipid targets, as well as weight loss is very well integrated in this. So the core mandate is defeat therapeutic inertia, assess and adjust therapy every 3 months, and achieve early intense multifactorial control, creating a legacy effect, permanently reducing the lifelong risk of micro as well as macro complications. And I would like to thank all of them and all of you for patient hearing, and team EMOCON, especially Supratik, Anchin, Dr. Meenal, Dr. Arvinda, and Dr. Rakesh Parikh. Thank you for your help.
Thank you, Dr. Purvi. Wonderful presentation. So any questions from the audience? So it's an extensive, wonderful presentation, no questions. So move on to the next topic.
Thank you.
But I can't find Supratik still now. And Dr. Goklani, are you there, Ratul? He was there for the last session as a chairperson, so he must be having lunch. So Akriti, Dr. Akriti Singh, oral presentation. Where are the organizers? I mean, the speakers are, we just hurried Dr. Purvi to finish. So what about the others? So do we move to the next session or we wait for the other 3 speakers because it was an extensive session. That's why we were hurrying so that. Eh? No, Anchan is there. Would you please call them? I saw Dr. Gokhlani going for lunch. I don't know where is Akriti and Supratik. So, do we end the session and we move on to the next session? Or anyone from the organizers? So, what do you suggest, Dr. Anchan? So, we end this session here for the time being. The other speakers can join in another session. So, we move on to the next topic. Thank you. Sorry for the brief interruption. We got hold of the speakers and they are back. So we continue with this session. And we have a very young Akriti Singh. Everybody knows her in Kolkata. So please go through the last topic. This is an oral paper presentation. Metabolic modulation meets mechanical relief. Marked improvement in severe OSA with semaglutide 2.4 milligrams after an inadequate early response to tirzepatide initiation. So it would be a wonderful session because it's comparing the two head-to-head fight drugs. We don't have many studies. So over to Dr. Akriti.
A very good afternoon to all present here. Thank you to the team of EMOCON 2026 for giving me this wonderful opportunity to present to you a very interesting case of obstructive sleep apnea and our global game changer molecules, semaglutide and tirzepatide. This story is called mechanical modulation and metabolic relief. So let me take you to the beginning of it all. But before that, let us see as to what are the tools to treat OSA as of now. As we all know, CPAP, continuous positive airway pressure, remains to be the gold standard for the treatment of OSA and has been approved so far with the best evidence. Out of the pharmacotherapy, what is there? the evidence is for tirzepatide, which has been approved in 2024 by the US FDA on account of the SURMOUNT-OSA trial published in 2024, which was done for people with moderate to severe OSA with severe obesity without T2DM. What about liraglutide then? There was a study called the SCALE sleep apnea trial, which was done for liraglutide, which showed that liraglutide indeed decreased obstructive sleep apnea on polysomnographic evidence. However, it has not been approved yet because of various reasons. And the new drug which is in pipeline for the treatment of OSA is eroxybutynin, which is a novel antimuscarinic agent, and atomoxetine, an SNRI. This combination has undergone a trial called the MARIPOSA trial, the phase 2 data of which has already been published. However, it is in the pipeline and has not been approved yet, as the phase 3 data is still pending. So let me take you to the beginning of this story of a 54-year-old man who presented to our OPD, type 2 diabetic, diagnosed 5 years ago. He is well controlled on anti-diabetic drugs and his HbA1c levels are well within target limits. He is a non-hypertensive, has dyslipidemia, and he presented with complaints of loud snoring since the past few months and excessive amount of daytime sleepiness, which led to a car accident, and so he came to the OPD for further advice. On examination, the vitals are stable and an obesity-focused history was taken. The weight of the patient, 91 kg. The BMI, 25.4. Neck circumference was 36 centimeter and a stop bank scoring was done, which came out to be 6 out of 8 scores. Currently, he is on medication 100 milligram sitagliptin, 30 milligram of pioglitazone, 0.3 TDS of voglibose, glimepiride, 3 grams of metformin, and he has been SGLT2 intolerant due to recurrent episodes of balanoposthitis. For dyslipidemia, he is on atorvastatin, and for hypertension on telmisartan and amlodipine. So what next? We advise this patient polysomnography. So let us see what the polysomnography reports showed us. This patient came to us in 2025 March, and the polysomnography reports showed that the apnea-hypoapnea index was 32 events per hour. The oxygen desaturation index was 18.6 per hour, and the nadir of SpO2 was 84%. The polysomnography report showed that there was indeed a severe OSA. What next? We de-escalated the anti-diabetic drugs to initiate tirzepatide, which is the only pharmacotherapy agent which has been approved for the treatment of OSA. So tirzepatide was initiated at 2.5 milligram once weekly for 1 month, stepped up to 5 milligram once weekly for the next month, and so on. And the semaglutide and tirzepatide. This story is called mechanical modulation and metabolic relief. So let me take you to the beginning of it all. But before that, let us see as to what are the tools to treat OSA as of now. As we all know, CPAP, continuous positive airway pressure, remains to be the gold standard for the treatment of OSA and has been approved so far with the best evidence. Out of the pharmacotherapy, what is there? The evidence is for tirzepatide, which has been approved in 2024 by the US FDA on account of the SURMOUNT-OSA trial published in 2024, which was done for people with moderate to severe OSA with severe obesity without T2DM. What about liraglutide then? There was a study called the SCALE sleep apnea trial, which was done for liraglutide, which showed that liraglutide indeed decreased obstructive sleep apnea on polysomnographic evidence. However, it has not been approved yet because of various reasons. And the new drug which is in pipeline for the treatment of OSA is eroxybutynin, which is a novel antimuscarinic agent, and atomoxetine, an SNRI. This combination has undergone a trial called the MARIPOSA trial, the phase 2 data of which has already been published. However, it is in the pipeline and has not been approved yet, as the phase 3 data is still pending. So let me take you to the beginning of this story of a 54-year-old man who presented to our OPD, type 2 diabetic, diagnosed 5 years ago. He is well controlled on anti-diabetic drugs and his HbA1c levels are well within target limits. He is a non-hypertensive, has dyslipidemia, and he presented with complaints of loud snoring since the past few months and excessive amount of daytime sleepiness, which led to a car accident. And so he came to the OPD for further advice. On examination, the vitals are stable and an obesity-focused history was taken. The weight of the patient, 91 kg. The BMI, 25.4. Neck circumference was 36 centimeter and a stop bank scoring was done, which came out to be 6 out of 8 scores. Currently, he is on medication 100 milligram sitagliptin, 30 milligram of pioglitazone, 0.3 TDS of voglibose, glimepiride, 3 grams of metformin, and he has been SGLT2 intolerant due to recurrent episodes of balanoposthitis. For dyslipidemia, he is on atorvastatin, and for hypertension on telmisartan and amlodipine. So what next? We advise this patient polysomnography. So let us see what the polysomnography reports showed us. This patient came to us in 2025 March, and the polysomnography reports showed that the apnea-hypoapnea index was 32 events per hour. The oxygen desaturation index was 18.6 per hour, and the nadir of SpO2 was 84%. The polysomnography report showed that there was indeed a severe OSA. What next? We de-escalated the anti-diabetic drugs to initiate terzepatide, which is the only pharmacotherapy agent which has been approved for the treatment of OSA. So terzepatide was initiated at 2.5 milligram once weekly for 1 month, stepped up to 5 milligram once weekly for the next month, and so on. And the patient was advised CPAP, which is a gold standard for the treatment of OSA. When the patient comes to us for follow-up after 2 months, we are really perplexed to see that the weight of the patient has remained 91 kg still, same as 2 months back, even though the patient was initiated on terzepatide and pioglitazone and glimepiride were down titrated. So we would expect the weight to come down. But we were really perplexed to see that there was no response. Not just the weight control, but the glycemic control had also worsened. The patient was not willing to continue terzepatide, and that was not because of the GI intolerance, but it was because of the inadequate response, both in terms of glucose control and in terms of body weight. However, we convinced the patient to initiate semaglutide 1 milligram, including financial reasons. And patient initiated with SEMA 1 milligram once weekly, stepped up to 1.7 once weekly, followed by 2.4 milligram once weekly, and so on. So the patient continued to come for follow-up over the period of 1 year, and the SEMA dose titration was done as per the GI tolerability. So the patient came to us, when the patient came to us after 1 year in 2026 March, we advised a repeat polysomnography. So till now, patient had received 2 months of terzepatide therapy, followed by 10 months of semaglutide therapy, out of which for the last 6 months he was on 2.4 milligram once weekly. And let us see what the new polysomnography report after 1 year yielded to us. Now we were perplexed to see that the numbers had normalized. The apnea-hypoapnea index came down from 32 events per hour to 7.4 events per hour. Oxygen desaturation index from 18.6 to 8.7 per hour, and the nadir of SpO2 from 84% to 86%. The stop bank score from 6 out of 8 points were reduced to 4 out of 8 points. And the polysomnography report said that it was indeed mild OSA. So this is a chart which shows the decrease in the body weight, which was moderate, 12%, and the corresponding BMI change, which was 6.7%, led to a profound decrease in apnea-hypoapnea index, which was 77%. The apnea index also decreased by 96%, hypoapnea index by 46%, and oxygen desaturation index decreased by 53%. So this is a pictorial representation which shows the profound decrease in the sleep disordered breathing pattern over the 1 year. The anthropometric and the risk screening changes in the graphical representation over 1 year, and the oxygen related improvement, SpO2 and oxygen desaturation index in the follower. So, what did we learn from this case? What is the novelty of this case? After thorough review of systematic literature, first, this case perhaps is the first documented evidence of obstructed sleep apnea reduction with semaglutide in a person with type 2 diabetes without severe obesity. Just to recall that the SURMOUNT OSA trial, which was done with tirzepatide, was done for moderate to severe OSA in a severely obese patient with a mean BMI of 39 without type 2 diabetes. In our case, the patient is only overweight. He had a BMI of 25.4. He was overweight by international definition, only obese by the Indian definition. And it was done in a patient with type 2 diabetes with severe OSA. Despite only a moderate weight loss of 12%, the AHI reduction was profound. It was 77% AHI reduction was seen over a period of 1 year with semaglutide therapy. And semaglutide showed improvement after an unsatisfactory short early tirzepatide course. OSA and obesity stand out to be two entities which are deeply intertwined and have a bidirectional relationship. OSA can lead to obesity and obesity can lead to OSA. But the pharmacological modulation of this axis is still evolving. So obesity can cause OSA via various mechanical changes like narrowing of the airway, decrease in caudal traction, and by increased release of adipokines and cytokines, neurohormonal changes which can lead to OSA. And in turn, OSA can also lead to obesity via various hormonal changes. So there is a balance of orexigenic and anorexigenic hormones, sympathetic activation, RAS activation, release of inflammatory mediators which affect these end organs and cause OSA. And the SGLT2 inhibitors, the GLP-1RAs and the twin incretin tirzepatide attack the very core of this pathophysiology, decreasing the beneficial effects in and causing the beneficial effects in OSA. This is an obesity OSA wheel of endotypes, and each spoke of this wheel represents anatomical, physiological and pathological mechanisms by which the OSA, metabolic effect and obesity are interrelated. In our literature, a piece still remains missing. This is a graph which compares the number of events reduction, the apnea-hypoapnea index, events reduction per hour. The SURMOUNT OSA trial showed that the tirzepatide reduced 22 events, whereas the scale sleep apnea study for liraglutide showed that there was a moderate AHI reduction of 6 events per hour. Our case report shows that semaglutide in our case reduced 25 events per hour of apnea-hypoapnea index. Till now, the slimming sensation semaglutide has no RCT or even a case report which has been published yet that has shown that semaglutide indeed decreases obstructive sleep apnea on polysomnographic indices. However, there is a small study, an RCT of 15 patients which is currently ongoing in China in patients with type 2 diabetes with moderate to severe OSA, which is due to be completed this year. And with this, I hope the India and in different parts of the world, we undergo more trials and there comes more data which proves the efficacy of semaglutide in obstructive sleep apnea. Thank you so much for your patient hearing.
Thanks, Dr. Akriti. It was very well presented. But just one thing to ask, you have given tirzepatide for 2 months and at a dose of 2.5.
2.5 for 1 month and 5 for 1
So
month.
what made you switch to semaglutide?
Right.
So is that the time to actually assess that this drug is not good and you have to switch to another?
Right. So since there was no response in terms of weight and even a poor glycemic control because of the cost constraint, the patient was not willing to take tirzepatide anymore when it was not actually yielding any adequate reduction in weight nor any improvement in symptoms of OSA.
So non-responders are there. You cannot just tell that tirzepatide did not work and semaglutide worked because you are giving semaglutide to the maximum dose. So naturally, a non-responder to the twin creatine,
but
this is due to pharmacogenomics also. Not all patients respond equally to all drugs. Anyways, it was a wonderful thing and one of its kind, and hope so more patients we look after in OSA, how it works. Thank you for your wonderful presentation.
Thank you so much.
So we have our last.
So we are moving on to the last topic for this session, which is gestational diabetes and postpartum diabetes, short-term crisis and long-term consequences by Rutul Gokalani. Sir, may I request you to kindly come on the stage?
He was there, but yeah, he came inside. Somebody can call him if at all, because
So before we move on to our next session, so one announcement is there for regarding the postgraduate quiz. Screening will be in the Rose Boardroom from 9 a.m. tomorrow, and the final quiz will be from 10 a.m. So those interested or those who have not given their names yet may give their names to the delegate registration counter today. So as the next speaker comes, who will be starting with the next sessions shortly.
Can we have the slides, please? Sir Sleevy slides. Uh, good afternoon, everyone. So there were some technical issues, and now we move on to the session of rewriting outcomes. So we have with us one of the most famous endocrinologist of the city, Dr. Sujay Majumdar sir. Sir is the senior consultant diabetology and endocrinology Apollo Multiple Specialty Hospital, Kolkata. Multiple credits to his CV, has been an examiner for multiple examinations, vice chairman of the Royal Chapter of Physicians of Ireland Indian chapter, with more than 30 publications to his credit and multiple book chapters. So sir will be giving us a hype about the innovator SEMA, because whenever a biological comes up, then we need to understand whether they are at par in terms of efficacy and safety for a large group of population. So moving on, the session is all yours, sir. Please.
Thank you, and my heartfelt apologies for the delay, which was for reasons beyond my control. So basically, this is the overview of what I'm going to talk about today. So the first topic will be about the burden of obesity and the need gap for the pharmacotherapy, number one. And the next one is why and how Wegovy, or the innovator semaglutide, can transform the weight loss scenario. I'll be having some data of Wegovy beyond the weight loss, and lastly, I'll end with some real world data. So basically, it's entirely a talk. As we all know, this is a session sponsored by Novo Nordisk. So a lot of my talk will be primarily on the innovator semaglutide, that is Wegovy. Okay, so what about the burden of obesity and the need for the pharmacotherapy? Now, we all know that there are multiple factors, contributory factors to the obesity. It could be a socio-cultural, it could be environmental, it could be epigenetic, it could be genetic, it could be physiological, it could be behavioral. In fact, a pathological abnormality contributing to obesity we find in only some of the dedicated endocrine cases like Cushing syndrome. The rest of them are all contributed by all these factors. So what is very important is to bear in mind there are certain habits that which we cannot change. For example, if you ask any of your younger patients, if the child is fat, the mother feels proud that he is healthy. And it takes a lot of time to explain to them that this is not healthy, this is unhealthy. So these concepts, these socio-cultural stigmas, they remain. And whenever we are trying to treat obesity, we have to overcome all these stigmas together. If you look at some of the global data here, so what we can see here, there are nearly 1 billion people all over the world affected by obesity, which includes around 764 million adults, 86 million adolescents, and nearly 71 million children. Remember, this is the starting point of the ticking time bomb. Because as that young child, as he grows older, he tends to remain healthy, and as the days go by, he becomes more and more healthy in that sense. Now, the greatest number of this obesity, contrary to the popular belief, it's in the low and middle income countries where there's a double burden of malnutrition and obesity. Even in the developed countries, if you find out, obesity is primarily a disease of the poor, not of the affluent rich. And what about the Indian picture? There are nearly 254 million people with obesity. And if you look at the prevalence, 4 in 10 women in India, obesity is primarily a disease of the females, because 4 out of 10 women are affected by the abdominal obesity. And this is a sort of a geographical distribution of how the obesity varies in different parts of the country. We can see here that there is actually, geographically, there is a bimodal distribution. One is in the extreme South India and other is in the extreme North India. So why are we concerned about obesity? It's not because nowadays we have got the GLP-1 or the GLP-GIP combinations available. But the fact is that, and this is something which we do not want to accept, or which we have been refusing, is that obesity is the starting point of many diseases. Obesity increases the cardiovascular disease risk by around 80%, increases the risk of type 2 diabetes by around 74%, increases the risk of kidney disease, increases the MASH, increases the PCOS, hypertension, osteoarthrosis, something which is not mentioned in this list. And to be very honest, this is a relationship. Like a high-risk obesity, it can worsen the cardiometabolic risk factors, increase the blood pressure, increase the inflammation, increase the dyslipidemia, endothelial dysfunction, and ultimately leading to adverse cardiovascular events, heart failure, arrhythmias, and last but not the least, sudden death. So does the reversal of obesity help? The answer is yes. A 2 to 5% reduction of obesity reduces the hypertension and the hyperglycemia. 5 to 10% drop in obesity reduces the stress continence, the PCOS, dyslipidemia, asthma, airway disease. 10 to 15% reduces the MASH, the obstructive sleep apnea, the gastroesophageal reflux disease, and also the osteoarthrosis. And there have been studies on semaglutide which have done it, but I'm not going into those in my presentation today. More than 15% weight loss can bring about a significant change in the CV disease, CV mortality, and the heart failure with preserved ejection fraction. That is the beauty of the innovator semaglutide, because all these actions have been demonstrated in different studies done with the innovator semaglutide. So this is the management protocol of obesity. Lifestyle is there in each and every stage. But pharmacotherapy basically starts when the BMI is more than 27, and surgery basically with adiposity-related complications at a BMI more than 30, and at a BMI more than 35 when there are adiposity-related complications. But however, there is a big gap between all these stages. As we all know that the medical nutrition therapy, physical activity and psychological interventions, obviously they do help in the lesser degrees of obesity, but they can contribute at best to 3 to 5% weight loss. As soon as we need to go for a higher degree of weight loss between 25 to 30%, you have to think about either a bariatric surgery. So there was always this gap for people who needed between 15 to 20% weight loss, and for them, the GLP-1 or the GLP-GIP are the best ones which we can use. So how and why Wegovy transforms the weight loss? So basically, this is the neural and hormonal modulation update. Basically, this class of molecules, it acts on our brain hypothalamic homeostatic settings. So basically, they lead to an increased satiety, they lead to an increased reduction of appetite, and also they also lead to an increased energy expenditure. So this is something which is very important, and as we know, at the bottom of your list, you can see the satiety hormones. These are the ones, and the hunger hormones that come from the ghrelin comes from the stomach. So basically, all these factors, this entire limbic system, basically connected from the vagus to the area posterior of the medulla, and from there up to the hypothalamus, this entire thing, this mesolimbic system, the GLP-1 class of molecules, they basically act on this class of molecules. So Wegovy basically works on these other different centers, like the hindbrain, like the area posterior and the nucleus of tractus solitarius, and from there are projections into the midbrain. So this is the circuit which gets affected by the Wegovy. That's why when patients, it's not only with Wegovy or semaglutide, any GLP-1 basically acts on this pathway. So what has been seen more often than not is that the patients, after having a small amount of food, they feel very contented. They do not want to have anything extra. So basically, the dose of semaglutide that is used for the treatment of obesity is basically a semaglutide up to a dose of 2.4. So which patients are suitable for Wegovy? Basically, patients more than BMI 27 with at least one weight-related comorbidity. It could be in the form of cardiovascular disease, diabetes, metabolic syndrome, osteoarthrosis, and so on and so forth, or a BMI more than 30 with no requirement of a weight-based comorbidity. So these are the specific conditions where we use it. And if you have the sites of action of the spectrum of action of semaglutide, they've got action on the kidneys, they've got action on the brain, as I've told, they've action on the pancreas, they've got action on the alpha and the beta cells, they've got action on the intestine, they've got on the fat and other tissues, they've got action on the cardiac fat, they've got an effect on the coagulation pathology. So it's basically a multifaceted action that this class of molecules have. So that is the reason why a product like Wegovy has been extensively studied in the phase 3 trial programs. You can see this is nearly 30 million people. They have been subjected to Wegovy. And if you have a look at it, apart from the ordinary trials, the step 1 till step 8, then you have got the step 9, which looked at the effect of semaglutide on osteoarthrosis, step 10 on obesity and prediabetes. Then we have got the SELECT trial, which basically looked at obesity and the cardiovascular outcomes. Then the STEP heart failure preserved ejection fraction. Then the ESSENCE trial on the MASH outcomes. Then the STEP up, where they went up to a dose of 7.2. So there's a vast network on program. And what we can say in all these trials, there have been more than 3,500 patients from India who have been studied. So how do you go for the dose escalation of Wegovy, as was shown in the STEP trials? So you start in a dose of 0.25 milligram, give it for 4 weeks, then increase it up to a dose of 0.5, then it increase it even up to a dose of 1 milligram, then 1.7 milligram once every 4 weeks, till you attain a final dose of 2.4 milligrams, or as we say, the maximum tolerated dose. So it's not necessary that each and every patient has to go to a dose of 2.4 milligram. You go to the maximum tolerated dose which the patient can tolerate. So this slide I'm going to skip for the shortage of time. But what are the weight loss benefits with Wegovy? So 9 out of 10 patients, they have got a 5% weight loss. 3 out of 4 patients have got a 10% weight loss. Nearly 50% patients have got a 15% weight loss. And 1/3 patient, that is nearly 33% patients, they've got a 20% weight loss. And this is obviously something which is related to the dose. And if you look at this, this is a summary slide of the STEP clinical programs. You can see here, compared to all the other parameters, semaglutide 2.4 performed much better. So far as the weight reduction is concerned, in fact, perhaps the only agent which can offer a sharp competition to semaglutide is tirzepatide till date. The other ones which are going to hit the market in the next 2 years, so this is not the right time to discuss about them. But till date, semaglutide has shown one of the very best weight reductions, in addition to the cardiovascular, renal, and hepatic benefits. What is also important is that there is, in addition to the fat loss, there is also a loss of the lean mass. And this is something which can be increased by doing proper isometric exercise, vitamin D supplementations, and so on. So basically, this semaglutide study showed there's if the patient is put on an isometric or an isotonic exercise, then basically there can be a significant improvement in the hand grip strength. I mean, that is the way by which you can prevent the sarcopenia, which often happens with this class of molecules. So what about Wegovy beyond the weight loss? So basically there has been seen, this is something which we have talked about earlier. So optimal weight loss has a dose-dependent and tissue-dependent biological effects. So what we can see that if the dose becomes higher, then we can find, in addition to the weight loss, effects in the other systems of the body. So what are the other benefits that we talk about when somebody is on this class of molecules? So we have seen here that we have seen up in the STEP programs, we have seen up to 21% weight loss. The HbA1c drop up to 2.8%. And then we have got a 26% improvement in the SUSTAIN 6 of the 3-point MACE. There's 69% improvement in the heart failure with preserved ejection fraction. That is in the STEP heart failure preserved ejection fraction trial. In the STRIDE trial, there was a 13% improvement in the maximum walking distance. In the kidney outcomes, as we saw in the FLOW and the remodel trials, it has shown up to 24% improvement in the kidney outcomes. Liver benefits in the ASCENT study up to 37%. And all-cause mortality has been shown to be reduced by as much as 19 to 20%. Now, I feel it's probably not out of the way to talk about this SELECT trial, which was one of the largest cardiovascular outcome trials, 41 countries, more than 17,000 patients. And what we saw in that SELECT trial was there was a 20% reduction of the 3-point MACE in obese people without diabetes. So this improvement did not come by a glucose control. It came primarily by the reduction of obesity. There's a 28% reduction in the non-fatal MI, an 18% reduction in the composite heart failure. So this is all an RCT data. What about a real-world data? I'm going to show you here 2 real-world studies, which I think all of us should know. One is a SCORE study, and the other one is a STEER study. So the SCORE study was basically a comparison between semaglutide users versus non-semaglutide users. It was a retrospective longitudinal observational cohort study, and the cohort characteristics was an obesity with a BMI more than 27, age more than 45, a history of a previous MI, stroke, or a peripheral arterial disease, and no prior history of diabetes. The STEER study was, and it remains till date, the only head-to-head comparison. You can say this is a real-world study, true, but this is not an RCT. But this is the only real-world study which has compared semaglutide with tirzepatide. It's a retrospective study, again, a similar sort of a criteria, BMI more than 27, age more than 45, history of previous MI, stroke, no prior history of DM. So let us go to the studies one by one. The SCORE study, it showed the effect of the cardiovascular outcomes in people with obesity and diabetes in the real world. Now we have got the SELECT study, which looked at the CV outcome in the RCT setting. This SCORE study looked at the outcomes in the real world, and it was a huge cohort, more than 27,000 patients, and patients were propensity score matched is 1:2 with non-users to balance the baseline characteristics, and they were followed up until the end of the continuous treatment, end of data availability, initiation of a non-semaglutide GLP-1 or a GLP-GIP, bariatric surgery or death. So that was the end point. And the primary outcomes was obviously the 3-point MACE and a revised 5-point MACE, which means the occurrence of MI, stroke, hospitalization for heart failure, coronary revascularization, and all-cause mortality. So what did they see here? So basically you can see here there was a significant improvement in the 3-point MACE, something around, I should say, 45% reduction of the 3-point MACE, and also there's something like 57% reduction of the 5-point MACE. And this was in a real world scenario. So obviously, this particular real world data validates what we found out in the SELECT trial. The STEER study, this was the one that I was talking about. So that is the beyond the dual GLP-GIP height. What we know so far, the SURMOUNT studies, they've all shown that tirzepatide is superior to semaglutide so far as the weight reduction is concerned, so far as the glycemic control is concerned. What tirzepatide lacks so far is the cardiovascular outcome data in a head-to-head comparison with semaglutide. So this was a real-world study. You can see here, it's a very busy slide, but basically you can see here there was a huge number of patients, nearly 1.5 lakh patients with an established atherosclerotic cardiovascular disease in nearly 23 lakh patients, age more than 45 years. And you can see here a huge number. The patients were divided into two groups. One group had semaglutide 2.4. The other group had tirzepatide given in the standard dose. So ultimately, these patients were included in the study, and this is how they were done. So ultimately, after the exclusion, we had in the semaglutide pre-matching around 14,000 patients, and ultimately 10,000 patients were included in the final study. Similarly, with the tirzepatide arm, so nearly 10,000 patients in both the arms. Now, what did we find out? So far as the revised 3-point MACE is concerned, so what is this revised 3-point MACE? I'm going to talk in a minute, but what you can see that semaglutide definitely showed a significantly better 3-point MACE compared to the tirzepatide. And if you can see here, this forest plot, what it shows here, that basically the revised 3-point MACE, the 5-point MACE and the 3-point MACE. So what is the revised 5-point MACE? That's MI, heart failure, stroke, coronary revascularization, and all-cause mortality. So what they found out here is that basically it is in general, this 3-point MACE, this 5-point MACE, and this revised 5-point MACE, they were actually, it favored semaglutide, as you can see here. This is a real-world study. Again, I'm explaining, this is not a sort of a head-to-head RCT, but this is something what they found out, and this was a study which was entirely based in USA. So what they found out here was that in real world, patients with overweight or obesity with atherosclerotic cardiovascular disease, but without diabetes, the primary endpoint showed that semaglutide was associated with a lower risk of cardiovascular events compared to tirzepatide. Again, let me forewarn you, this is not an RCT. I'm not sure when this RCT between sema and tirzepatide is going to take place, but till then, we have got this data. So to summarize, the innovator semaglutide 2.4 has shown significant benefit in up to 1/3 patients achieving a 20% weight loss. The significant outcome benefits have been noticed in the glycemic control, CV outcome benefit, in the SELECT trial and the STEP heart failure trial. They've shown significant benefit. Now we have got a host of generic semaglutides hitting the Indian market. We should remember one factor, that all these generic semaglutides, they have been shown to be equivalent or very similar to the innovator semaglutide in only two aspects. One is the obesity loss, obesity reduction, and the second one is the glucose control. These semaglutides, these generic semaglutides, they do not have any data till date on the cardiovascular outcomes, on the renal outcomes, on the outcomes on the MSLD and so on and so forth, something which the innovator Wegovy has got. So before we go on to prescribe a semaglutide or a generic semaglutide for any of these patients, we should keep these facts in mind. I'm not saying that this generic semaglutide will not produce any cardiovascular outcome benefit, but so far we do not have the data. That's the only thing. Maybe after 5 years, we'll be having enough data and we can talk about that. So with that, I end my presentation. Thank you very much.
Thank you so much, sir. As sir rightly said, that in the era where we are having so many biological similars, understanding why innovator SEMA has a superiority, probably as of current time is there because of the available data that is present. And the last important slides which sir quoted was the data about the real world data about the STEER, where we are
I mean, you are pondering about using SEMA or TESA. That's something which is important. Sir, can please be here. I think we'll have questions at the end of the session. We can continue with the next session where we will be again understanding why innovators SEMA in the era of so many biological similars available being now, still probably is a single strong agent where in terms of the CKM outcomes. And the next speaker is Dr. Tetanka Chaudhary. Can we have Sir's slide, please? Yeah. Okay, they're putting up the CV. So Sir, again, doesn't need too much of introduction. Sir is one of the most senior consultant endocrinologists at Apollo Hospitals, Gleneagles, Kolkata. Has been the president of Kolkata Diabetes and Endocrinology Forum, multiple publications to his credit. So we'll move on. Sir, the dais is all yours.
Thank you very much. I thank the organizers and Novo Nordisk for inviting me to speak here this evening. Now, can I regulate from here? এটা সুজয় মজুমদারের লেকচার। Ananya, is it Dr. Ananya here? Yeah, can you check that? When they are doing this, it's a pleasure to speak again. Thanks to Supratik. Now, what I'm going to speak today is about a semaglutide obesity dose. So we'll be speaking about 2.4 milligram. I'm not talking of the diabetes dose at the moment. Having said that, our focus, if we talk of Wegovy, or if we talk about semaglutide obesity dose, probably it stands on the two pillars or two studies. One is STEP, one is SELECT. STEP established the 2.4 as an obesity drug. SELECT study established the cardiovascular outcome. Now, if you look at the STEP study, I'll go through slide by slide. I was part of the STEP 2, which is 2.4 plus diabetes. Now, till they started, the interesting question is that the weight reduction was less in the diabetic group in comparison to the non-diabetic group, as you would all appreciate. Now, that is a big question why people talk about insulin resistance, other meds you are using in diabetic, which might have probably caused less weight loss. I often wonder whether incretin pathology itself in diabetic patient had also a contribution or not. And second thing that, till I get my slides, is that in diabetes, you do not have semaglutide a BMI cutoff. It says that if you have got diabetes, you can use at any BMI. However, my take is that if you are using it at a BMI less than 22, you should individualize the patient. Because there are three very clear-cut terms. One is sarcopenia, one is frailty, one is malnutrition. So unless you consider this in lower BMI, you are going down a slippery slope. Now that I have got my slides, so once again, I am commercially supported by Novo Nordisk, and I will just go through most of the things you are very aware, because more talking has been done on anti-obesity drug in recent times than any other molecule. However, just to remind you that cardiovascular, kidney, liver, and metabolic diseases represents a substantial global health burden. So you can see here, MASH 411 million people, obesity 878, type 2 diabetes, you have got 510 million, CKD 850, and CVD 621. So you have got, so you have got this, and it says more than 4 million deaths per year is due to this burden. Now, if you look at cardiovascular, kidney, liver disease, then these diseases rarely occur in isolation. So if you are obese, you are inviting other problems too. And it is very important to understand that MASH itself, obesity and type 2 diabetes are major contributor to cardiovascular disease, that we know, because it goes down an inflammatory pathway of endothelial dysfunction, and that leads to this. So 612 million people are living with CVD globally. Prevalence is expected to rise by 90% in 2050. Now, 4 out of 5 people with CVD had overweight or obesity, and almost 68% linked to elevated BMI. 1 in 3 people had CVD, 50% death. In fact, if you look at the data for cardiovascular intervention, 70% people with a CAB, GPTCA, etc., have got diabetes in the background. So, if you look at the CKD MASH, then again you find the same problem. In a CKD patient, before he dies due to a renal cause, he will die probably due to a cardiovascular event. If you look at MASH, so why is fatty liver or MASLD a cause of cardiac? Because MASLD is the seat of insulin resistance and inflammation. So this insulin resistance and inflammation in a MASLD is a predictor of cardiovascular or hepatic worse outcome. Therefore, MASLD itself is also a huge problem in terms of cardiovascular health, and that's what it is saying. Now, if you look at shared cardiometabolic modifiable risk factor, multimodality and cardiovascular event, you will find some commonality. I am very pleased to share that in DRCP I wrote an article about MASLD and its outcome in hepatic and cardiovascular outcome published in November 2024. So that's what I was trying to talk about, how MASLD can be a risk factor for cardiovascular and hepatic. Now let's look at the commonality. Hypertension, hyperglycemia, pro-inflammatory state, dyslipidemia, and abdominal obesity. Why we keep talking of abdominal obesity? Because, as I told you, when you get more nutrition and they have to store it in the body, that goes to its home, adipocyte. Now, if you eat more, adipocytes increase in number and size, they have an ischemic death, there is an inflammatory cascade leading to an endothelial dysfunction. Now, if you eat more than the spillover, and you have got ectopic fat, now they have got the same cascade of inflammatory pathway. Therefore, and among this, when the fat gets deposited here and there, your abdomen has the white adipose tissue. Brown adipose tissue is good. White adipose tissue is the seat of inflammation and insulin resistance. That's why we keep talking of the abdominal obesity. Now, Wegovy has a unique and robust evidence. As I told you at the beginning, that it stands on the 2 pillars, the STEP and SELECT. STEP, you can look at the data. It is very impressive. Step 1, you look at the physical function and quality of life. If you reduce weight, starting from osteoarthritis, up to your OSA, up to your fatty liver, and the more established cardiovascular outcome, diabetes, and metabolic dysfunction. Step 2 talked of USA at 24% with semaglutide. We know also from the flow study the benefit of SEMA, but we are talking today about 2.4. SELECT talked to you about the cardiovascular. So look here at the cardiovascular diseases. Again, SELECT, STEP, heart failure. You have got step 10. You have got ESSENCE for MASH. I think we also have STRIDE for peripheral arterial disease. So some are emerging, some are established. Wegovy at the risk reduction is a major adverse cardiovascular event and all-cause mortality data. So we have got a lot of Indian patients as well. What is the one liner I want to add, because you can go home and read SELECT and STEP as much as you want. purpose of presentation is to convey some information that you can carry home. The best information I can give you with Wegovy is, or semaglutide high dose, that the benefit starts beyond weight loss. Because the benefit, the cardiovascular outcome, benefit starts 3 to 6 months, even before, by 3 months, by the time you have not really developed a significant weight loss. So what is the message? That it has got a huge anti-inflammatory impact and probably other pleiotropic effect that is doing it. Therefore, this is a very important information that when we are talking of MACE reduction, we of course have the advantage due to weight reduction, glycemic control, your dyslipidemia are correcting, your blood pressure minimally you are correcting. So all these are helping. But over and beyond this, and you know, over and beyond benefit of semaglutide has reached Alzheimer's disease and Parkinson's also as emerging evidence because of their effect on amyloid plaques in the brain as well as their effect on the dopamine receptors. So this molecule is going way beyond what we anticipated. For this evening, it is the Wegovy reduced MACE which I want to convey. First, the sustained statistically significant in MACE reduction with semaglutide 2.4. And it's all the more pronounced in Asian patient, and that is very interesting for us. Wegovy treatment effect on MACE was independent of extent of weight loss. Now, that gives us a lot more confidence that it is not just about weight loss. It is very difficult to actually lose weight. When you are talking to a patient and tell them to lose weight, remember that you have to take the guilt away about the weight, because 50 to 70% of this is because of the genetic and epigenetic factors. What we need to understand is that a fat man is more hungry. Your satiety hormones are more impaired. Therefore, we need help. And nothing is more sensational over the last few years than having semaglutide in high dose and Wegovy that's doing this. MACE reduction is evident soon after initiation. This is the logic why I am saying that the benefit is over and beyond the weight reduction. So separation of MACE curves appeared before maximum weight loss. So before the weight loss came, your MACE was improving. So there is something else contributing. 80% of the MACE risk reduction with Wegovy is mediated by factors other than just weight loss. I do understand that weight contributes to this. If you look at Wegovy led to consistent reduction in MACE regardless of male, female, baseline HbA1c, baseline EGFR, LDL-C, bypass, HbA1c, MASH. So you take into the entire factor, but the benefit was consistent in all the group. And numbers needed to treat, as you know that how many patients you need to treat to get benefit in one. NNT 3-point MACE was 58 at 4 years, 25 in extended, and CKM was 11. You need only 11 people to treat to get the benefit of one. So you can imagine how strong a molecule we are talking about. Wegovy has demonstrated improvement in the multiple modifiable risk factor. So that shows your waist circumference, CRP, SBP, DBP, and triglycerides. So all the risk parameters were taken care by this molecule. MACE up to 36% of Asian people. So the benefit was even more among us and surpassed other anti-obesity medication superiority. Now, if you look at this chart, I want to draw your attention to the SELECT. And you can see it is a completed study. And of course, others have got various green, red, and other patches. So you have got one confident molecule of semaglutide in full dose that's giving you the benefit. Real world evidence of SEMA, I think my friend and colleague Dr. Shuja was talking to you about some real world evidence, but sometimes people talk about real world evidence and RCTs that this is better, that is better. I believe they are complementary to each other. If you want to extract evidence, you need an RCT. You don't extract evidence from a real world study. However, expression of an evidence you have obtained from RCTs is pronounced in your real world studies. For they are complementary. Once you get in a controlled environment of RCT and find it in that uncontrolled environment to have the same benefit, that complements each other. Therefore, they are complementary rather than anti to each other. Level update in India, Wegovy is indicated to reduce the risk of major adverse cardiovascular event. Of course, we know the 3-point MACE, and of course the obesity. Now, ESC says semaglutide is the ESC recommended obesity medication, should be considered in patients with overweight, obesity, and says without diabetes to reduce. So obviously, we had the step studies. So you can use it even without diabetes. Semaglutide overpowers tirzepatide across multiple patient profile. Well, as we all know, choosing the molecule is the wisdom of the prescriber. When you are writing a molecule, you have to think whom I am writing. It is not very fruitful to discuss the benefit of one molecule versus another. When you have got a patient in front of you, he should be part of your decision making. If you are talking that this patient has got, why you want to use a molecule? Are you using it for anti-obesity? Are you using it for obesity plus, that is diabetes? Or you have got comorbidities like cardio or renal problem? Then you have to go for the molecule that has got maximum evidence. And undoubtedly, semaglutide at this point of time has maximum evidence starting for cardiovascular, composite renal outcome, and of course emerging data in MASH, your OSA, osteoarthritis, Alzheimer's, Parkinson's, peripheral arterial disease, name it. Therefore, I leave it up to you to take a decision. But if you are, of course, a Puritan, if you are a pedantic person and saying, I just want to treat chronic obesity, obviously you have probably some anti-obesity drugs may go in terms of evidence more than. Innovator SEMA versus generic. This is the most important discussion we are doing now. We have got so many, we are flooded with your biosynthetic SEMA. Now let me tell you first at the outset that the biosynthetic SEMA that is present in the market is licensed for diabetes, not for obesity. DCGI has not approved it for obesity. It has approved it for diabetes. Having said that, I take the point that it will have 3 to 6 kg or some benefit in the weight reduction, well said. So the original versus biosimilar, and we have got the biosynthetic molecule, is licensed for diabetes. Second part of it is that all the evidence we are talking about, we have established a bioequivalence, or we have established at least a pharmacologically PK/PD with the original innovator. However, that alone is not suffice in the scientific parlance. That's why FDA comes with some warning regarding long-term effect, regarding the evidence it should come in the phase 3 trial. And also, even the syringe, about their agglutination, about the impurities. When you talk of the impurities, we are shown that some 130-40 patients, they have the head-to-hand and established for HbA1c and weight loss. When you talk of the impurities, they are less than 1% or something. That is also acceptable. Now the problem comes, what are the impurities? These impurities are different from the biosimilar or the technology that innovator uses, because we are doing an artificial. Now the question comes whether they in the longer run will have the same effect. And can we claim that this molecule is as good as the innovator in terms of source study and flow study? In a resource controlled limited state, you of course can use it. My one-liner is that I discuss with the patient all the options available. Tell them what is there and not, and it's up to him, the cafeteria choice, to take which is with the one. But something better than nothing, we can, of course, we have got a huge resource setting problem, so probably it has got a place, and I'm not anti to it. Make in India will always be pleasure, but of course coming with some more evidence would have been very good. Why innovators SEMA are synthetic? You can see here FDA has also some warnings, but the questions are raised that whether they will have, the synthetic will have the same attributes as the innovator, even the syringe, even the pen, even the long term, even the storage. So there are issues that we can't ignore and wrap it under the blanket, but we have to think about that. I saw one of the companies telling that we import the pen. Remember, often they write FDA approved. FDA is approving the process, not the molecule. So we have to understand that. Why prefer innovator? Wegovy, they have also come down in price. So in appropriate patients, where there is no resource limitation, I have no hesitation in saying that Wegovy has the evidence of select and stay. Others don't. Of course, I told you that now the biosynthetic is not, of course, as an obesity license anyway. Thank you very much.
Okay, sir. Take your seat. Any questions from the audience?
So do we have any questions?
Yes, sir, please.
So I think it was wonderfully demonstrated about the synthetic, the biosimilar, and the originator. I have heard from the Novo Nordisk itself that they actually tried to develop this synthetic semaglutide way back, but they actually failed. So with these new synthetic products which are there in the market, which are actually way different from the recombinant DNA product, we can actually figure out that. So do we actually think that before 6 months to 1 year of use, we can comment on how these products will work? And actually, should we use these particular products in the patients whom we are actually targeting obesity?
Sir, we'll take.
Thank you very much. I think both of us have mentioned it partly. Now, my first is that you said, can we use the biosynthetic in obesity? And if you say a short answer is this drug, the biosynthetic is not approved for obesity. It is approved for diabetes. It will have some weight benefit, but it is not an obesity drug approval. Number two, you are saying 6 months down the line, will it have all the attributes that the innovator molecule has? See, the problem is that I'm not saying it because I've been brought here, invited to speak on behalf of Novo for Wegovy. I'm saying it because that what we are trying to do is we have got a molecule, gone through a very rigorous trials, phase 2, 3, 1, whatever, then came to the market. And now we are just copying that molecule in a biosynthetic. We are trying to make an equivalence in terms of the molecule and the chemistry of it. Because it's only a 31 amino acid, so it is easy to produce that in laboratory. Now, I'm not a molecular biologist, but I've heard that there are talks about DPS, drug product substances, and drug substances, and their folding and stereotactic configuration of a molecule. Having taken that all that probably this is doing this, then also you find that what they established is biochemical and bioequivalence with the molecule, done the PK/PD studies. So I'm not anti to it because it will have some place in this vast thing. But to just say in a sweeping statement it is as good as an innovator without any phase 3 trial, I think will be stretching it a bit far.
Yeah, I'll just add a comment here, and why I'm asking this and why we are discussing this so much. It is not just about copying empagliflozin or dapagliflozin, which are very small chemical molecules. These are biological molecules composing of amino acids, and of course, these robust CVOT data, these robust, renal data, it's very hard for even the generic companies to actually generate, because it involves millions of dollars. So we have to look at the real world studies only regarding these molecules.
No, I do not have problem if they can produce a biosynthetic similar. All that I want is to establish the science. That's it.
If I may add a word here, Tirthankar, I'm not saying everybody is equivalent, but some companies have actually shown a real PK/PD and a bioequivalence data. So for us, and also there has been some very good data regarding the impurities, the adjuvants, and all this data is there. And there have been some head-to-head comparisons with, say, in fact, I'm not going to mention the name of any particular company, but there have been at least 2 or 3 companies who have compared semaglutide 2.4 innovator versus semaglutide 2.4 generic. So that comparison has been there, and the data has shown almost a bioequivalence. But again, as I mentioned in my talk, that it is primarily regarding two endpoints. One is the obesity reduction, and the other one is the glucose control. There is no data at all about the cardiovascular, renal, hepatic, and other data which are simply not there. So far, as Tirthankar rightly mentioned, I'm not getting into the molecular biology, and one comes from recombinant DNA, other comes from the polypeptide. I'm not going into that, because that is not my cup of tea. We look at the clinical results. Clinical results is that so far, these molecules have shown almost an equivalent benefit in the HbA1c drop, in the obesity reduction, but in nothing else.
Yeah, I think even the evidence that has been put is very small. And I do agree that what they came out with had similarity with the original innovator in terms of HbA1c, not for obesity, and for the weight reduction in that range. But what I'm saying is that the end-all statement. I don't think it's the end-all statement. We need some more evidence would have helped us. But encouraging what they have been trying to do, that's absolutely true.
One more thing about the manufacturing. Some biosimilars are telling that we are manufacturing and others they are not. So how it confuses the whole fraternity. So there should be some strict regulations. So it's very difficult. It's very early to tell. So sir, any comments on that?
The data at the moment is that there are only 2 or 3 companies who are manufacturing the API. The rest are all borrowing it from them and making their own products. So we have got around 50 companies hitting the store with this generic semaglutide. In fact, how many of them have got this actual data? I mean, I've seen the data because I've been a part of a few ad boards in some of these companies where they've shown some very impressive data, and these are studies done by them. I'm not mentioning any particular company, but apart from that, the remaining ones who are there, what is their exact data? Because a lot of these people, they're using the Chinese API, number one. Number two, many of these other companies, they do not have that capacity to produce a semaglutide 2.4. Up to 1 milligram it is there, but up to 2.4, not many companies have got this capacity, but they're still marketing 2.4, and so the final conclusion is for you to decide.
Right, so as both our experts have rightly highlighted that, sir, I have a question. Sometimes patients come to us who are already on a GLP-1 analog, and then now with patient being aware that the prices have come down, like they insist that suppose somebody is on an innovator, you switch over us to something which is cheap. So at that point, it becomes difficult. So we do not have data about especially the immunogenicity part because these are all biological ones. So what is your take on that?
2 or 3 companies have shown their immunogenicity data, that is the baseline antibody levels and the antibody after 6 months. I'm not mentioning any particular company, but at least 2 or 3 companies have shared this data in certain ad boards. And so far as the immunogenicity is concerned, these molecules, at least as for these 2 or 3 brands that we're talking about, they're shown to be pretty safe. So that immunogenicity data should not, but again, as I told you, we cannot generalize about each and every of these 50 brands that are coming up.
And as sir has shown, one of the most interesting data was the NNT for the renal outcomes, because flow was one thing which showed us that it was rather stopped much before time. So I think probably in upcoming times we have this molecule. I do not know about the innovator or the off-patent generic ones, especially in the renal related part. Now we are concerned with the obesity, diabetes, patients having spectrum of kidney disease with diabetes and use of this drug. So probably in GLP-1 analogs near future, they will be in the forefront in the renal diseases. So what is your take on that part?
Well, in the renal disease at the moment, we have got quite a good number of products. We started with the ARBs, then we had the SGLT2 inhibitors, then we had the Finrenon, and now we have got the semaglutide. So basically, semaglutide, again, the data with semaglutide was primarily, if I'm not, correct me if I'm wrong, with the flow trial, it was essentially with Ozempic. That is up to a 1 milligram dose. So, yes, the data is very good. The data is very good, and right now in people who can afford, and particularly in the ones who are refractory ones, so far as the albumin reduction is concerned, in fact, we can go use all the 4. We have got people who have not responded to ARBs, have put them on SGLT2, have not responded, put them on Finrenon. There is still a residual disease left. So these people, we can certainly try the semaglutide. There's no problem with that because the flow data is there.
Thank you very much. I think it's quite established that we have got cardiovascular and renal, composite renal outcome study, the flow and soul. So there is no doubt that it will be beneficial as part of the flow study. So I think that there is no doubt about it, that this is beneficial. Now, I think what she raised is a very important, that if the patient comes and tells you, I think communication is the bottom line. We have to tell everything to the patient, what we have and what. There's a patient choice whether they want to take the. Like today I discussed one and they said, no, I'll go for the cheaper one. So it's up to the patient, as long as you give your disclaimer. Thank you.
Thank you, sirs, for a wonderful session, and we close the session here. And audience, for the audience, you can move to the other hall because this is the last session of the day. Thank you.
Thank you, sirs and madams, for the excellent session.